Hello, my name is Madelyn Hafer. My toxicology project is over the copper toxicity and poisoning in the ovine species, better known as sheep. Throughout the PowerPoint, we will discuss two different experimental cases where the effects of copper toxicity and poisoning are shown. So, to get started off, we first need to know a little about copper toxicity in sheep. Acute poisoning may follow intakes of 20 to 100 milligrams per kilogram. Chronic poisoning may occur with daily intakes of 3.5 milligrams per kilogram when grazing on pastures that contain 15 to 20 parts per million of copper and low concentrations of molybdenum. You might ask, why molybdenum? Well, molybdenum has been shown to reduce copper levels by increasing the amount excreted in urine and interfering with gastrointestinal problems. So grazing a pasture with high copper and high molybdenum may not affect your sheep as much as grazing pastures that have high copper and low molybdenum. The next important thing to know is the clinical signs of copper poisoning in your herd. Affected animals may become increasingly weak. They may wander or head press. They may become jaundiced, which is the yellow coloring of the skin and the mucous membranes. They will show shallow and rapid breathing and will have dark or black urine. Though sheep may show these clinical signs, it is often too late to perform any kind of reversal. Sheep with low-grade toxicity will experience fever and lethargy. A low-grade toxicity may be reversed, but it is very difficult and requires a watchful eye. Copper toxicity that causes complications such as hemolytic anemia, anuria, or hepatotoxicity is treated by administering oral penicillamine to your sheep, ranging from 250 milligrams every 6 hours to 750 milligrams every 12 hours, or dimercaprol, 3 to 5 milligrams intramuscular every 4 hours for 2 days, and then every 4 to 6 hours. Even in this case, sometimes copper toxicity is fatal despite treatment. This study done by the University of Sydney includes pre- and post-mortem findings. In Property 1, 6 of 1,700 first-cross ewes died within a week, in early December of 2007. The owner had also noticed several weak ewes. The ewes were mostly in fat condition and were grazing abundant improved pastures, with no supplementary feeding. Molybdenum-enriched superphosphate had previously been applied to pastures, but not within the past 10 years. Property 2 includes 1,600 first-cross ewes. In late January of 2008, the owner noticed that while almost all of the ewes in a mob of 250 5-year-old ewes were in fat condition, one was dead and another was dull and sick. The owner noticed the sick ewe had gray skin and gums. She died within 2 hours. The ewes were running on a paddock of regrowth oats with some ryegrass and subterranean clover. He recalled that he similarly lost 3 ewes over 2 days in early January of 2008 after he moved a mob of 183-year-old ewes. In the following clinical pathology results, it shows that copper levels were elevated in the liver, kidneys, and blood. Liver enzymes and bilirubin were elevated, indicating liver pathology. The PCV in U2 was very low, as expected subsequent to a hemolytic crisis. Both ewes also had a marked neutrophilia, presumably in response to liver necrosis. This next study was done by the Veterinary College of Norway in 1976. This study includes pre- and post-mortem findings and the structural changes in erythrocytes and organs of the affected sheep. 4 one-year-old sheep were dosed with 0.2% aqueous copper sulfate solution as a drench for 6 days a week. During the first 48 days, the animals were given 10 milligrams of copper sulfate per kilogram of body weight once a day. Later on, they received 20 milligrams per kilogram twice a day. They developed clinical symptoms after 7 to 13 weeks of dosing. 2 conventionally fed sheep without copper supplement served as a control animal. Blood samples were drawn at weekly intervals during the accumulation period and with a few hours interval during the hemolytic crisis. For determination of bilirubin in plasma, a plasma analysis was taken. Hemoglobin, red blood cell, and white cell counts were performed by conventional methods. Smears of peripheral blood obtained from the anterior jugular vein were stained for routine examination by light microscopy. The peripheral blood smear results are as follows. All of the experimental animals were found to have normal hematological values with respect to hemoglobin, hematocrit, red blood cell, and leukocyte count during the accumulation period. Erythrocyte morphology and differential white cell count were without remarks. At the time of the hemolytic crisis, the differential cell count shifted from lymphocyte dominant to neutrophilic with about 70% neutrophils. The monocytes counted for about 20% of the white cells in the last days prior to the hemolytic crisis. In the accumulation period, Heinz bodies were only occasionally seen in up to 1% of the erythrocytes. However, 2 to 4 hours before measurable hemoglobin could be observed in plasma, Heinz bodies were found in 50 to 60% of the red cells. At that time, GSH in the erythrocytes had fallen below normal values, and an increase in methemoglobin content in the red cells was measured. The number of erythrocytes containing Heinz bodies increased during the crisis for up to 90% of the red cells. Heinz bodies were commonly seen free in the plasma and were assumed to originate from lysed cells. On the left, Figure 1A is a blood smear showing Heinz bodies in most erythrocytes. Figure 1B on the right shows Heinz bodies that are visible in ghost cells. Electron microscope exam results are as follows. The ultrastructure of erythrocytes during the accumulation period was unremarkable. From electron microscope examination of blood samples drawn at the hemolytic crisis, the erythrocyte population could roughly be divided into different cell types according to morphology. 1 was normal erythrocytes, indistinguishable from the erythrocytes of control animals. 2, red cells containing Heinz bodies, which were distorted in shape. They were, however, found to have normal electron density of the cytoplasm, suggesting no leakage of hemoglobin. 3, red cells, revealing partial or complete loss of hemoglobin, but retaining their Heinz bodies. Fragmentation of the cell membrane was commonly seen at this phase of hemolysis. Figure 2 is an electron micrograph of Heinz body that is located in a protrusion in an erythrocyte. In the 2 first mentioned cell types, discontinuities of membranes were not observed. The 3-laminar structure normally present in red blood cells, which was also demonstrated in the red cells of the experimental animals during the accumulation period, could not, however, be seen in the red cells of blood drawn at the hemolytic crisis. Several Heinz bodies were usually present in one cell. The Heinz bodies were of varying sizes and were almost invariably attached to the cell membrane. Fragments of erythrocytes and free Heinz bodies in the cytoplasm were frequent findings. Figure 3 is the electron micrograph showing a ghost cell of erythrocyte containing one large H and several small Heinz bodies. The arrow indicates the defective membrane. Livers from the sheep that died and those of the sheep that were killed showed similar lesions. Focal necrosis without regular location within the lobes were characteristic findings. The necrotic area contained slight numbers of inflammatory cells. In the kidney, the proximal tubules showed degenerative changes. The tubular lumina contained casts of granular material evidently containing hemoglobin. The glomeruli were moderately swollen. In the spleen, intrafollicular necrosis were regularly found. The phenomenon seemed to be associated with obstruction of central follicular arteries. Intracellular erythrocyte and fragmented erythrocytes were commonly seen, as were iron-containing pigment granules, and phagocyting cells in the red pulp and the parafollicular area. Figure 4 on the left is a kidney section. The arrow indicates tubular necrosis. On the right, Figure 5, is a spleen section showing follicular necrosis. The following images were from a more recent necropsy done on a lamb who died from copper toxicity. The diagnosis of copper poisoning is based on the housing and feeding history, the clinical signs, and postmortem findings of a pale tan to bronze-colored liver and dark red or black kidneys. The diagnosis can be confirmed by laboratory identification of high kidney copper concentrations. The figure on the left is an example of the bronze-colored liver. The figure on the right is an example of the gunmetal appearance of the kidneys. So, finally, if we can't reverse copper toxicity, how can we prevent it? Well, prevention depends on avoiding feeding the copper-rich diets to susceptible animals. Sheep breed, age, and the presence of dietary copper antagonists such as iron, sulfur, and molybdenum all influence the efficiency of absorption. The availability of dietary copper varies between different feeds.